Welcome back to our final lesson in the Women's Health Point of Care Ultrasound curriculum. As a review, in our last lecture, we talked about some of the other findings seen in pregnancy, including miscarriages and early pregnancy loss, subchorionic hemorrhages, corpus luteum cysts, uterine rupture or perforation, how placental abruption is a clinical diagnosis and not a sonographic diagnosis, gestational trophoblastic disease, and we introduced cervical insufficiency. This lesson will end our series on POCUS for women's health, and will focus on non-obstetrical findings present in patients with traditionally female reproductive organs. As has been true for most other exams in this module, transvaginal ultrasound is generally superior to transabdominal ultrasound for most gynecologic indications. So, if you plan to routinely use this technology for gynecology exams, I again encourage you to devote some time to practicing this skill. The general preparation for an exam to look into gynecologic matters includes choosing an appropriate probe for the exam, most often the curvilinear probe or intracavitary transvaginal probe, managing the bladder, making it full for transabdominal views or empty for transvaginal views, and placing the patient in the supine position. You should drape them for privacy and surveil the anatomy of the pelvis prior to investigating the clinical question you have in mind. This will be an introduction to these topics, which again likely represent just the tip of the iceberg with regards to the various uses POCUS could have for providers wanting to offer comprehensive women's health care. Our first clinical question will consist of assessing intrauterine contraceptive devices when there is suspicion that the device could be malpositioned, expelled, or if there's difficulty with placement or removal. IUDs are generally hyperechoic linear structures that are shaped like a T located inside the uterus. To determine if placement is proper, we have to first focus on the relevant anatomical landmarks. Landmarks to determine proper placement are the myometrium, cervix, and endocervical and endometrial stripes when they're not obscured by the IUD. Here, I've highlighted them for us. So we see the uterine myometrium here in this teal color surrounding the pink endocervical and endometrial stripe. And then we have our cervix here on this transvaginal view in the yellow color. So now we can zoom in on the actual IUD itself, which is clearly seen inside this patient's uterus. A couple important artifacts that help confirm the identification of an IUD are posterior shadowing, which is generally present, and reverberation artifact, which may or may not be present depending on the angle of insonation and the type of IUD placed. The landmarks to determine proper placement are the myometrium, the cervix, and the endocervical and endometrial stripe when they're not obscured by the IUD itself. Once we properly identify our landmarks and we can determine if there is in fact an IUD present, the clinical question becomes, is this IUD appropriately positioned within the uterus? The checklist for proper placement includes placement inside the uterus, on or over the endometrial stripe, and this should be symmetrically surrounded by the myometrium on both sides. And when scanning through the uterus, the arms of the IUD should extend laterally into the transverse plane of the uterus. In the sagittal plane, there shouldn't be any extension of the IUD into the cervix. Here in this clip, we see a uterus in transverse view being scanned quite quickly from inferior to superior, with a properly placed IUD being traced up the endometrial canal to the fundus. So we see this hyperechoic structure here with posterior shadowing, and then right at the very end we see this lateral T shape with those arms coming out to the uterine fundus. So this is a properly placed IUD. Here are a couple of examples of malpositioned IUDs. On the left, highlighted in green, we see a transvaginal approach based on our intracavitary probe footprint with the uterus in the near field here. Also seen and conveniently labeled is an endometrial stripe up here and an IUD with some reverberation artifact present. We can see that the IUD does not lie in the uterine cavity and extend to the fundus, but instead lies lower in the uterus, extending into the endocervical canal, representing a possible misplacement or partial expulsion of the device. On the right, we see an intracavitary probe, and the uterus in the near field once again. There's the hyperechoic endometrial stripe, but here the highly echogenic IUD is located in the posterior portion of the myometrium. This represents an IUD embedded in the myometrium due to misplacement or migration. This is an interesting case report I ran into that was published in Iran back in 2017. I'll give credits to Drs. Azandaryani, Goddard, Desiree, and Farzghani. Here we see a curvilinear probe footprint with the indicator in the standard position on the left side of the screen. And we have both a transverse view here on the left and a sagittal view here on the right of the bladder, which we can identify by its midline anterior location up near the probe and its smooth-bordered anechoic appearance. We see some posterior acoustic enhancement on both of these slides and see the uterus and the surrounding structures a little bit brighter because of the ease of transmission of these ultrasound waves through the bladder. However, what's interesting to see here is that we have this bright, linear, hyperechoic structure sitting dependently in the bladder on both of these views, with posterior shadowing present, and nothing is inside the uterus. This is a case of either malplaced or migration of the IUD into the urinary bladder, which is a rare but noted finding in the medical literature. One of the most common reasons clinicians might order a pelvic ultrasound is to ask the question, is there suggestion of endometrial hyperplasia or neoplasia? It's also one of the reasons we most often see referrals to our procedure clinic for endometrial biopsy. Hopefully, by reviewing the findings we'll see here, we can cut down on biopsies that aren't indicated. When examining the endometrial stripe, a transvaginal ultrasound is, unsurprisingly, preferred due to the need for good resolution to accurately measure the endometrial thickness. The uterus should be identified in the sagittal view, and the endometrial stripe should be identified in the thickest distance noted. Measurements should be taken from the outer base to the outer base of this echogenic section, and not include any myometrium or intrauterine fluid if present. Here, the gold Waco Family Medicine icon logo color represents the appropriate measurement of the endometrial stripe, represented by the blue line. As clinicians, when we see a thick endometrial stripe on an ultrasound report, our first instinct is to often move towards a biopsy. However, it's important to remember that the appearance of the endometrium on ultrasound is extremely variable in premenopausal women, and that radiologists reviewing these images may not have the same clinical history that we have if we're doing a bedside ultrasound that helps us explain the findings and normalizes them depending on the patient's history. As a reminder, the lining of the uterus is responsive to the cyclic pattern of hormones prior to menopause. In the menstrual and early proliferative phase, the lining is shed and begins to rebuild, resulting in a very thin endometrial stripe. As the proliferation phase continues, the lining gets thicker and more echogenic, and after ovulation, the secretory phase continues to build the uterus and develops more glandular components that result in a relatively large echogenic stripe. Let's examine these in more detail. These three images come from women at various points during her menstrual cycle. This picture was taken during the menstrual or early proliferative phase. We see a relatively hypoechoic uterine myometrium with a thin, brightly echogenic stripe. Occasionally during menses, a thin layer of fluid can be seen in the cavity if using a high-resolution transvaginal probe. So once again, we see this hypoechoic myometrium and a very thin but very bright endometrial stripe. Later, in the proliferative phase, shortly before ovulation, this endometrial lining grows from about 5 millimeters at baseline to roughly 10 millimeters in thickness, or 1 centimeter. It can also develop a unique trilaminar appearance, which we can appreciate here with these three lines going here. This is the basal layer on either side where the calipers are located, a functional layer that is a little bit hypoechoic relative to the other parts, and then the inner interface between the two layers of endometrium that results in a brightly echogenic line. Meanwhile, after ovulation, the secretory phase maintains and thickens the endometrium and prepares it for possible implantation of a product of conception. The secretory phase demonstrates a myometrium that is more or less homogeneous and, at its thickness, up to a couple of centimeters in thickness for some women. So this is the widest portion of the endometrium. It's also most uniformly bright and represents the secretory phase in a pre-menopausal woman. The previous slides demonstrate that endometrial thickness is not the most reliable assessment in premenopausal women. If concern for hyperplasia or cancer exists in these women, consultation with an OBGYN or possible EMB or hysteroscopy may be indicated. However, the clinical picture does get a little bit clearer and the utility of ultrasound gets more apparent when considering symptomatic postmenopausal women. This picture was taken from Voluson's Empowered Women's Health presentation. Here, we see a heterogeneous, thickened endometrial lining. While it's not measured here on this slide, it's easy to see using the scale on the side that the machine thickness is, or the machine scale shows that the thickness of this endometrium is at least 2 centimeters. In a postmenopausal woman who came in with vaginal bleeding, this is strongly suggestive of endometrial disease such as carcinoma. Some numbers that you can use as screening cutoffs when examining by transvaginal ultrasound are general thickening to greater than 15 millimeters in most premenopausal women. Now, there will be a significant portion of women whose normal thickened endometrium during the secretory phase could approach 2 centimeters or 20 millimeters, but using this as a screening cutoff is appropriate. Thickening greater than 5 millimeters in postmenopausal women is uniformly recommended to be pathologic unless proven otherwise by biopsy. And focal or heterogeneous echogenicity of the endometrium, regardless of thickness and regardless of the woman, is considered to be a poor portending sign that there might be some hyperplasia or neoplasia present. Similarly, if you don't get a clear distinction between the myometrial and endometrial border, this can also be a sign that there may be something pathologic at play. Let's next turn to a couple common cystic structures seen in women, especially in premenopause. These images, which I took from Cambridge University and Drs. Turan, Bahat, and Seton, show 2 views of a round, small, anechoic collection on the cervix. These represent nabothian cysts, a common and benign finding that could be mistaken for a gestational sac or for free pelvic fluid if not fully examined. Bartholin gland cysts are often encountered by primary care and OB providers as painful erythematous swellings near the labia or the vaginal introitus. There may be a history of drainage or previous disease in the area. While ultrasound is not routinely utilized for these diagnoses because they usually aren't very subtle, I have used ultrasound before to assist in drainage when my initial attempt at lancing and draining was unsuccessful. Placing a needle under ultrasound guidance is sometimes helpful when these abscesses are small or mobile. The technique for imaging these relies on use of a linear probe, which should be covered in a single-use condom or glove. Here we see a round, heterogeneous structure with septations and internal flow or fluctuance consistent with an abscess. I typically will cover my probe with a large tegaderm, place a needle to aspirate, and then place a word catheter if I can to drain these Bartholin gland cysts and prevent them from recurring if possible. Following use, these probes should be cleaned with a high-level disinfectant. One of the most common findings on ultrasound is the finding of leiomyomata, or uterine fibroids. Whether symptomatic or incidental, understanding the appearance of uterine fibroids is helpful for a variety of clinical scenarios. The next few slides will show us several examples of the varying appearance of uterine fibroids. While their appearance and location may vary, the classic leiomyoma is a well-defined hypoechoic mass that arises from the uterine myometrium. The FIGO classification system helps organize fibroids by their appearance and location within the uterus. While the scope of this classification system is beyond the scope of this lecture, it does help to generally think about fibroids as being either submucosal, intramural, or subserosal in their largest 3 categories to help determine if they're contributing to symptoms such as vaginal bleeding or pelvic pain. Here in the image on the left, we see a sagittal view of the uterus being taken transabdominally with the curvilinear probe. Posteriorly, there's a large, round, hypoechoic mass representing a large intramural fibroid. And on the right, there's a transvaginal view of the uterus, again in the sagittal orientation, with a large, round, hypoechoic mass arising from the outer surface of the uterus, which represents a subserosal fibroid. So to point these out with the pointer, here we've got this curvilinear footprint. We've got our indicator on the left. We have in the near field, anechoic structure representing the urinary bladder. We have a hypoechoic structure representing the myometrium of the uterus. And then here we have this well-circumscribed round mass arising in the middle of the myometrium, likely representing a transmural fibroid. And then here we've got a intracavitary or transvaginal probe. Here we're seeing the uterus, its normal contours are around here. Here's our endometrial stripe. And then we have this really large circular mass coming from the surface or external surface or serosal surface of our uterus, which represents a subserosal fibroid. Whenever a patient's presenting with AUB, in addition to fibroids, adenomyosis should also be on your differential. Adenomyosis can be diagnosed through high-resolution transvaginal ultrasound, showing extension of the endometrial glandular tissue into the myometrium. This is not usually a finding you differentiate on point-of-care exam, but I wanted to show you an example of what this might look like for completeness' sake. The ovaries and the adnexa have already been covered to a small degree in our ectopic pregnancy lesson, which is the most common reason to perform POCUS on these organs despite the limited utility we discussed in that lesson. However, there may be a few clinical scenarios in which you want to peek at the ovaries to evaluate patient concerns. Again, standard imaging technique for these structures is through use of a transvaginal ultrasound probe. However, I do want to show you the tip I have for imaging these structures using a transabdominal technique. Let's pretend that this very professionally drawn graphic represents a transverse cross-section of the pelvis, with the yellow trapezoid representing the urinary bladder, the purple oval, the uterus, the gray ovals, the ovaries, and the adnexal regions, and these little squiggles on either side here representing bowels of, or loops of bowel, which will commonly overlie and obscure the adnexa. Here, I'll add an ultrasound beam path that we can use for transabdominal imaging of the uterus. Translating most patients laterally in an attempt to view the adnexa will lose the acoustic window of the bladder and instead move to an area occupied by bowel loops. Gas and the peristaltic movement within the bowel will scatter the ultrasound beams, largely obscuring deeper structures like the adnexa. For this reason, most of the time, the adnexa will not be visible using this approach. However, if the probe is instead rocked to one side from the midline, or translated to the contralateral side and angled through the bladder, the adnexal structures will sometimes come into view. But when in doubt, you need a transvaginal ultrasound to figure it out. Simple ovarian cysts are commonly seen on ultrasounds. While we think these arise from hormonal stimuli, they are usually clinically harmless. However, very large cysts can predispose women to pelvic pain or even ovarian torsion, so they should be followed with serial exams. The features that define a simple ovarian cyst, other than its origination from ovarian tissue, are that these cysts be encased in thin and smooth walls with a completely anechoic interior. This differentiates them from more complex cysts, which can contain septa or vascular supplies and comport an increased likelihood of malignancy. While size of these simple cysts may vary, cysts that are greater than 3 centimeters in size generally need to be followed with serial exams. In this clip, we see a curvilinear probe footprint at the top of the screen and a transverse view of the bladder and the right adnexa. While the bladder is decompressed, we see the cyst is not obscured by bowel gas and easily visualized here by a completely anechoic structure. There's the uterus there. And it's nice and clean, completely anechoic. That's a nice simple cyst. Hemorrhagic cysts, on the other hand, are common causes of acute and subacute pelvic pain. These arise when a growing cyst or a vessel breaks open and results in a sudden hemorrhage that leads to blood accumulation from a bleed into that simple cyst or an ovarian follicle. While the cyst is still thin-walled and will lack intracyst vasculature, the hemorrhage and the subsequent clotting of this blood can result in some internal echogenicity as opposed to the completely anechoic findings of a simple cyst. So here we see this cyst right here, And we see these internal septations. We see it's not completely anechoic. Over here, this may be a tubal ring sign, or it may be a corpus luteum cyst. It's a little bit hard to know exactly what that is. But here you can see that this is a cyst. It's adjacent to the ovary, and unfortunately, there looks like there's some clotting blood on the inside. Here are a couple of ways that hemorrhagic cysts can show some internal echogenicity. On the left, this is an example of a cyst that's interlaced with these bright connecting linear signs. It almost looks like a honeycomb or a stepping stone or like a pizza, I don't know, something over here, the cratered moon. But what this represents is a clot that's forming, and these bright septations are actually due to fibrin cross-linking up during the coagulation cascade. The right side of the screen shows a older clot, most likely, which shows up as more of a homogeneous, poorly echogenic clump inside this cyst. Hemorrhaging cysts can by themselves be painful, but they can be life-threatening if they rupture into the peritoneum. So patients who present with or develop abdominal pain should be examined with a fast exam. Non-ruptured cysts usually involute within a couple of months of detection, but unless symptoms persist or the cyst is large, those cases should be re-imaged in a couple of months to ensure that they are indeed reducing in size. Dermoid cysts are also found arising near ovarian tissue. As you probably remember from histology class back in medical school, dermoids arise from multiple layers of germ cells that produce conglomerations of developed tissues such as hair, teeth, muscle, endothelial tissue, etc. A characteristic finding within dermoid cysts is a Morse code-like pattern of dashes and dots. So here we see relatively hypoechoic round structure, but then on the inside we have these punctate sort of hyper echoic lesions that are sort of dot dash. There's a dash, there's a dash, there's a dot, a dash. And this Morse code-like appearance of dots and dashes with the matter strewn linearly into otherwise hyperechoic background probably represents linear components like hair. There's some Morse code. If you want to figure out what it means, go ahead. Another common finding on ultrasound of the ovaries is this polycystic appearance. However, before we delve into whether or not this is truly PCOS or not, there's a big caveat to get out of the way. And that is that PCOS is not diagnosed by ultrasound alone. So the recommended diagnostic criteria for polycystic ovarian syndrome is the Rotterdam criteria, which can include polycystic morphology on ultrasound, but these findings are only one of the three criteria, with two of the three being necessary for a diagnosis. Off the cuff, do you remember what the other two Rotterdam criteria are? In addition to polycystic morphology seen on ultrasound, you also need either a clinical or biochemical evidence of hyperandrogenism, so that could be things like hirsutism, elevated testosterone, acanthosis nigricans, and the third criteria is ovulatory dysfunction, specifically oligo or anovulation. Now you also have to rule out other hypothalamic, pituitary, adrenal, gonadal axis disease to exclude those. But let's get back to the fun stuff and look at these ultrasounds again. To diagnose polycystic morphology of the ovaries, findings must be inside the ovaries, duh. And they either need to be cystic in appearance that results in a ovarian volume greater than 10 milliliters, or the presence of a large number of follicles. So here I've got this nice round structure representing an ovary. We see the hilum here in the middle, which is relatively hyperechoic, but then we have these anechoic follicles bordering all around the outside of the ovary. They all seem to be about the same size relatively, so there's not like one dominant follicle that's about to rupture out and cause ovulation, and so this is pretty characteristic of polycystic ovarian morphology. Now, the initial Rotterdam criteria placed the number of follicles necessary to be seen to make this diagnosis at 12. But more recent literature has suggested raising this number to at least 20 follicles per ovary. A study in 2013 that looked at the difference between these two numbers showed that using a cutoff of 26 follicles increased the specificity of this diagnosis. However, this was also using much higher technology ultrasound than what we have available in the point of care setting. So for now, I'd recommend sticking with 12 follicles identified per ovary and then following up with formal imaging if the diagnosis is murky. The last ovarian pathology we'll touch on today is ovarian torsion, which refers to the twisting of the ovary around its own vascular supply or pedicle. This can result in significant pain, lymphatic and vascular congestion, and ultimately lead to ovarian ischemia and necrosis if not resolved quickly. Ultrasound findings for ovarian torsion rely on identification of intra-ovarian flow using Doppler modes of ultrasound. In the top image here, we see the normal left ovary here on the right side, which has power Doppler images showing flow inside the ovary. We can see the hyperechoic nature, we see the little anechoic follicles, and then we see these brightly positive power Doppler signals from inside the ovarian parenchyma. We compare that with, on the right, an ovary that, if this is in the same patient, is much larger than the left ovary, probably due to lymphatic congestion, and absence of internal flow. So we see these peripheral flows here on the PDI, but nothing coming from inside the ovarian parenchyma. Another finding that can be seen is the whirlpool sign, which shows twisting vasculature seen down here. And you can emphasize this by putting on color flow, which will show these alternating patterns of forward and backwards flow that, if you translate the probe, sort of looks like it's twisting or whirlpooling as you move down the axis of torsion. These are also signs that you can see in testicular torsion as well. Now, one caveat is that ovarian torsion, unlike testicular torsion, is unique in that the ovary gets a dual blood supply from both the gonadal artery, like the testicular artery goes to the testes in males, but also gets anastomoses from the uterine arteries too. So seeing an absence of blood flow may not happen if there is still some blood flow coming from collateral circulation. So the sensitivity for sonography for diagnosis of torsion, based on this study at least, is less than 75%, although the findings of no flow or the whirlpooling sign were very specific if they were seen. Lastly, I want to touch on breast point-of-care ultrasound, which is often underutilized in the evaluation of breast complaints in clinic. This is a great graphic that summarizes the typical breast findings you'd expect to find in women. Notice that there's a difference in the ratio of glandular to adipose tissue that changes with age, and that with increasing age, generally, the amount of adipose tissue also tends to rise. Thus, younger, more glandular breasts tend to be more uniformly echogenic, whereas older and more adipose breasts tend to be more hypoechoic. The clinical question when examining breast tissue is almost always about a concern that a palpable mass could be a malignant lesion. The differential for most common breast masses includes simple cysts, fibrocystic changes, malignancy, or palpable glandular breast tissue. Simple cysts are harmless fluid collections that appear uniformly anechoic with thin walls and no notable vascularity. Rarely these cysts can get infected, and things to look for there would be thickening of this wall, increased peripheral vascularization, maybe some internal echogenicity and fluctuance. But consider aspirating that if you find those findings, just to make sure that that's what that is. When in doubt, suck it out. That's what I always say. Fibroadenomas, on the other hand, are still relatively hypoechoic, but do have some internal structure seen. They are usually oval-shaped and well demarcated, but they'll have to have this kind of internal snow-like pattern that represents some of that fibrous tissue that's present inside the fibroadenoma. They will tend to follow the skin lines, and they generally are wider than they are tall. So they're lying parallel to the skin surface. Breast carcinomas, on the other hand, are very variable in presentation, but findings that would be typical for cancer include an irregular shape, just like we see on this lesion here, with angled or blurry borders. They're often oriented more vertically in the breast, so they're tall, not necessarily wide, although in this case this one looks wider than it is tall. Another clue is that while fibroadenomas tend to lead to posterior acoustic enhancement artifact, carcinomas will often have these little shadows that come down. In this image, we have a linear probe footprint up here, and we see an unknown orientation on the breast, but there's this hypoechoic lesion with irregular borders that's got some posterior shadowing, and so in this case, it would be appropriate to recommend biopsy. Lastly, some areas of the breast may be dense with glandular tissue. In this case, a relatively homogeneous clump of hyperechoic glandular tissue is present, which may be palpable on the outside. But when we look at it with ultrasound, we don't see any distinct borders or spiculations or fluid collections. We don't see any shadowing or increased vascularity, all of which are reassuring findings. And that wraps up our lesson on gynecology point-of-care ultrasound and our module on POCUS for women's health. As a review, we discussed evaluation of intrauterine devices for proper positioning. We talked about measuring the endometrial stripe in the setting of concern for neoplasia or hyperplasia, and we saw how it changed during the normal menstrual cycle. We talked about how to identify and classify uterine fibroids, examined some common ovarian and adnexal findings, and had a quick intro into breast ultrasound. I hope this module has helped you grow your knowledge and confidence interpreting scans for women that you may be taking care of. And I hope you stay tuned for our next module, which will focus on the use of POCUS to examine the heart.